Thank you very much. Well, thank you very much to Nick, who has gone. It's very kind of him to, be my little support act with the results of his little trial. Very kind of him. But now the main event. Amazing, really, isn't it? It's a real privilege to hear at such an early stage the results of such an important study, and I felt really honoured to be sat in the audience listening to those results and really quite blown away by the scale of what Nick has achieved with the Stampede trial. I'm going to talk to you about some slightly more mundane things from my little world of primary care. So firstly, to introduce myself, that's my commute each day. I live in Bristol, and I'm a GP in a practice in Nailsea, which is in North Somerset. Is there anyone from the Nailsea Prostate Support Group here today? We have one, recently set up. Is there anyone here from Prospect, the Bristol Support Group? Hello. So many of my patients are members of Prospect.
Can you recommend Nailsea to join the Fed?
I have said this to them. I presumed they had. Have they not joined?
No.
Oh, splitters. Right, no, I will. They are quite new and just sort of working out what it is they do. So I will make that suggestion to them.
I like the bridge.
Sorry?
I said the bridge. I like the bridge.
The bridge is lovely.
Where is it?
That's Clifton Suspension Bridge.
Oh, that is Clifton.
Brunel's.
The best bridge in the world. Yeah, that's my sort of commute over, and it always has the balloons there in the morning for me. They set them up for me. So I'm a sort of unusual breed in many ways, my wife would say, but medically I'm an unusual breed as well. So I trained in urology down in Taunton with Mark Speakman, who's now president of BAUS. And then I decided, I did 3 years of research for my MD, and my research was about quality of life. Very boring sort of, I won't go into the psychology stuff of what I did, but I did quality of life research in men with newly diagnosed advanced prostate cancer and their partners, looking at the effects of the disease and its treatment on men and their partners, and trying to work out better ways of measuring quality of life. And of course it was that taught me that, oh my word, there's a world of medicine outside the hospital and outside the operating theatre. And, I actually started to realise I quite liked talking to people, and I quite, people being awake when I saw them, anaesthetised. And so I jumped ship and became a GP, much to Mark Speakman's disgust. But then after a few years of general practice, I realised I quite missed urology as well. So I'm now 3 days a week as a GP, and I'm partner in my practice in North Somerset, and then 2 days a week I run a community urology service in Bristol. So we do, in my surgery, we do biopsies for men with raised PSAs, we do cystoscopies for men with hematuria, we do lots of stuff for men with benign prostate disease, and women, recurrent UTIs, all sorts of stuff. So we run a urology service, and I do lots of other things as well. So the other thing I've done, I'm passionate, as I think the message I'm getting is that I think you're passionate, is that the key to improving the care that men with prostate cancer and other urological conditions receive is in primary care, because I think we could do a lot better. So I have a passion that there's a lack of education in urology amongst primary care physicians in this country, as you'll see. We'll talk about that. And so I set up a thing called the Primary Care Urology Society last year, and we've now got 100 GPs signed up who've declared an interest in urology, and we're just about to hold our second meeting this autumn in London. And the aim of this is to try and disseminate good urological practice into GP surgeries. It always makes me feel a bit like I'm sort of entering the lion's den as a GP coming to a patient support group, but I imagine there are some of you who have had quite negative experiences of primary care. I'm hopeful that there are many of you who've had positive experiences of primary care. And I think what we're trying to do is to disseminate those positive experiences and that best practice, and to try and get it into the areas where it's not working. So that's my big passion and my big project. And then I do lots of other stuff. So I chair the Education Advisory Group for Prostate Cancer UK, just trying to help them with their education programme for health professionals, their Patient as Educators programme, all sorts of stuff that we do with PC UK. I've just been sitting with NICE doing again, mention that word, I've been working with NICE. I've been working with NICE on the prostate cancer quality standard, which we're going to look at in a minute, and I'm deputy editor of a journal called Trends in Urology and Men's Health, and I'm pleased to say that we commissioned Roger Can't see Roger now. I've commissioned Roger to write an article, which again we're going to discuss, but that's just been published in our journal. So Tackle makes it into our journal. So we're going to start with a sorry tale, which is just to sort of touch upon the state of primary care in the UK. And there's a real problem, isn't there? This is maybe there'll be some primary care doctors available on this planet. Let's head off into space and see if we can find a GP appointment. So there is a problem with primary care at the moment in this country. It is that would be my statement. It is a system under strain. Really, really, as a profession, I've been a GP for 10 years, and the state of morale in primary care at the moment is rock bottom. Absolutely rock bottom. I think we feel demonised by the media. I think we feel that we've just been turned into the sort of the nasties, and the sort of the reason there's a problem in the health service is all because of primary care. So we don't feel very popular, we feel very overworked, and we feel very unloved, and we're a very sad profession. For us. But there's lots of positives as well. But if you look at what's going on, 24% increase in GP consultations since 1998, 340 million consultations happening per year in UK primary care. The average person sees their GP 6 times a year. And you think, I've got 13,500 patients in my practice. That's an awful lot of consultations. And that's double what it was 10 years ago. So the number of consultations have gone up. Also, huge, breathtaking increase in bureaucracy and box ticking. If it was just me looking after my patients, I think I could achieve that. But the bureaucracy has gone mad.
Why is it?
Why?
Why?
Well, it's the modern disease. I don't think it's unique to healthcare.
Yeah.
My dad's a teacher, and you talk to him about what's happened in education, it's exactly the same. But a huge increase in consultation rates, a huge increase in complexity. The most sort of troublesome condition now is multi-morbidity. It's people with lots of things wrong with them. That, of course, is maybe where we come into play, because we're the only people who hopefully can manage multi-morbidity rather than one condition. The other problem we've got is a staffing problem. We've got 6 out of 10 GPs thinking about retiring early. I'm amazed it's only 6, because I'm 43 and I'm already thinking looking at my pension scheme. 30% of GPs are actively planning their retirement as we speak. And the other huge problem we've got an exodus at one end, but what we haven't got is an influx at the other end, and we're really struggling. The government's saying, we're going to train 8,000 new GPs. How the hell are they going to do that? They cannot fill the current training places. We've got, in June 2014, 451 empty GP training places on the GP training schemes. And if you come to the East Midlands, which is the worst in the country, nearly 2/3 of training posts are empty. It's drastic. So we have a problem. This is just a graph about rising demand, and you can see the sort of darker figures of the demand in 1995, and I'm colourblind, so the more grey figures to me are 2008, and you can see that demand has gone up, but demand has really risen in that elderly population with complex multi-morbidity, lots of problems with their health. And that is why, this is trying to explain why it is that there's a problem. And I've seen this sort of said before, we're just approaching this perfect storm, this surge of retirements from primary care, this horrible recruitment crisis, which is only getting worse, because as a junior doctor, when you look in the media and you hear people saying, it's a nightmare in general practice at the moment, the workload is untenable, it's awful, don't do it. They don't want to do it. They stay in hospitals and carry on. So we've got to improve the image of primary care if we hope to recruit. I think we're also, the other part of the perfect storm, there is rising demand, and there is a huge rise in expectation. I think what you guys, I'm saying guys because it's mostly guys here, but what you expect from your healthcare is very different from a cohort of people of the same age 20 years ago, 30 years ago, 40 years ago. You don't want to be old. You want to be living your life. You want to be doing stuff. You don't accept some of the problems with health that people accepted 20 or 30 years ago. You want your knee replaced, you want your hip replaced, you want your shoulder replaced, you want your bypass, you want your angioplasty, you want to be cracking on, you stuff I do. I don't have a problem with it, but it's causing a huge problem for healthcare, because how do we cope with that rise in demand and rise in expectations? And then the government throws stupid things into the mix, like, well, we know GPs are really struggling to man their surgeries and to do Monday to Friday, so let's give them Saturday and Sunday as well. Brilliant. We know GPs are in their surgeries from 7 in the morning till 7 at night trying to just keep up at the moment, so let's extend their surgery times 8 till 8, so that they're on there until 11 at night. So we're not happy about 7-day working and 8 till 8, because we just don't know how we're going to do it. So at the bottom, a demoralised workforce. And yet, when you survey a lot of patients, if you look at the GP survey, there's still a lot of people who are very satisfied with primary care. And I'm passionate that primary care, when it's done well, nothing else looks after people in the way that good primary care does. Because we know, I love the fact that I know my patients, they know me, I hope they trust me, and we have a really strong relationship. And I think that makes medicine a completely different thing than seeing some stranger who's just seeing you as a number and getting you out the door. And if we can maintain that in primary care, then we can continue to provide good quality service. This was from our practice, this is the friends and family test. So the first one we did, 93% of our patients would recommend us to friends and family. We're now up to 97%, because we don't let people not recommend us, which is keep them away from the box. We've learned. What does the future hold for primary care? Well, the future, this slide is, I love these quotes. Computers in the future may weigh no more than 1.5 tons. From 1949, Popular Mechanics, a riveting read. And the chairman of IBM in the 40s saying, I think there is a world market for maybe 5 computers. Okay, so the future isn't always what we think it's going to be. So all I can say about what is the future of primary care, it's not what it is now. We've said for years things are going to change. There is no doubt that things have to change, because we're facing challenges now that are unsurmountable if we don't change. The rise in demand that I've just been talking about, if we don't change, we are not going to cope, and we're going to go into meltdown. And Simon Stevens, who's just sort of taken over at NHS England recently, he's published this thing. I don't know if anyone's read it, but it is worth a look at if you're interested in healthcare in this country. This is called the 5-year forward view. And there's all sorts of things discussed in there. One of the things that's discussed is this concept of horizontal and vertical integration. And we're looking at this massively in primary care at the moment. So horizontal integration is about integrating at the primary care level. So practices coming together and working together to provide better care. Vertical integration is the idea of hospitals and primary care coming together and working together more vertically. Horizontal integration, certainly where I am, is the model that we're all looking at. And we're already looking at practices coming together as federations and merging to become bigger units. And the idea is that we'll become what's called multi-specialty community providers. We'll have social care, we'll have health care, we'll have pharmacists, we'll have nurses, physios, and we'll bring much more expertise out into the community, out into primary care, to try and help look after our patients better, and to get away from this horrible sort of binary model of primary and secondary care. You're either under your GP or you've got to wait 4 months to see someone at the hospital if you're lucky. So, I don't know what this will mean for prostate cancer patients, but I certainly think that my model would be, and this is what I'm interested in with my Primary Care Urology Society, is I mentioned that GPs have not got a strong background in urology and prostate cancer, but of course it gives us the opportunity to place people into the community who do have skills and expertise to look after people with urological conditions and prostate cancer in particular. And I think that's the opportunity that I'd like to see. We're coming together as groups of practices in North Somerset where I work, and of course the practices are all looking, well, John's got a real interest in urology, so why are we going to have to refer people to the hospital when we can just use him? So I suddenly become the urologist, not a urologist, Chris, I'm not trying to pretend I am, but I become the urologist, the community urologist for a bigger group of patients. And I can also disseminate what knowledge I have to my peers and support them in looking after people better. And I think that's where this becomes quite exciting, because if we can get that right, that could look an awful lot more attractive to patients than the sort of current model, which clearly isn't working. Now, I put a slide in there. How could we improve community prostate cancer care in the future? That's a question for you, really. Is there, from what I've said, is there anything you think we should be doing? Yeah, okay. Okay, yeah? I'm going to grab a drink whilst you say.
Unfortunately, my husband has just died of prostate cancer in the community. And I found the care in the hospitals fantastic. I found the care in our general hospital fantastic. I found the translation out into the community very poor. And talking to my GP, he says the state of the district nurse system is dire. You will not get any more than X, Chris. And yes, I will come to see your dying husband, and I'll be able to come to see him once a week.
Yeah, and I've seen a huge deterioration in our district nursing service in the 10 years I've been there, and I was so conscious of what an amazing service good district nursing can be to people, particularly for palliative care. And so that again, when this multi-service community provider thing comes in, I think that's one of the things we want to look at. We used to have district nurses assigned to our practice, and we felt like they were just part of our team, they were part of our practice. And now they're part of a, they work for the CCG.
If I were asked to prioritise, because you have to make priorities, out of hours care would be my first priority.
Absolutely, I would agree.
More than specialist prostate care.
Yeah, I agree.
We're very fortunate in Worcestershire. We have, I don't know whether it exists in any other part of the country, we have a survivorship program. I don't know if anybody else knows anything about it. It was a discussion that started about 4 years ago with the people within the hospital, and it worked. And there was discussions with Hereford, Gloucester, and Worcestershire.
Yeah.
And we met patients became part of the team. You know how the government want patients. Just as token. But we were part of that team, and now the survivorship program, we have an annual conference, and it's headed by a clinical nurse specialist.
Yeah.
We have now over 700 that are on this. It's a specialised computer program. I was put on recently, the end of last year, and now I get a note from the clinical nurse specialist to say you are due for a PSA test.
Well, it's music to my ears, because I'm going to talk about survivorship, so I might just cut you off, because we're going to cover that, because I think it's a really key element.
A wonderful element to work forward.
Definitely.
And to get people thinking about.
Okay, I'm going to move on, because I'm conscious of the clock. So, the other question I get asked an awful lot, because of course, as a prostate cancer group of prostate cancer patients and prostate cancer support groups, your obsession is prostate cancer. I'm a generalist. I can't afford to just concentrate on one condition, and this is the constant thing I get. Why isn't my GP more interested in prostate cancer? This is a terrible problem. Why aren't they more interested? And so, to try and answer that, I spoke at the Tackle conference a few days ago, and I tried to give us a bit of a sort of overview of this as well then. But firstly, the lack of training in urology. It's not an area of great interest. Loads of GPs who've done gynecology jobs, done paediatrics, done general medicine, ENT. Very few who've done urology, because it's not commonly part of core training. Only 40% of medical students, this is a study that was published in 2012, only 42% of medical students had a compulsory attachment in urology. So 60% hadn't done urology, and that attachment was typically 1 week in their 5 years at university. And in GP training, in the Bristol GP training scheme, I give them their urology training every year, which is a 2-hour talk, in which I have to cover urology. Quite a big topic. Oh, and they give me men's health as well. Like they're the same thing. So it's a huge problem. 2/3 of GPs are female. That is a problem, A, because it means they're more likely to have done jobs like gynecology and paediatrics in their training, and B, because men may not necessarily want to go and see a female doctor about these problems. They may be happy to do so. And female GPs, I think, are more likely not to have an interest in male-specific urological conditions.
One of the questions I'd like to say, because in London Cancer, they want to discharge prostate patients within 2 years into the community. Would that increase the knowledge, the training?
We're going to talk about that as well. And I think the other thing is this whole issue about other clinical, as this sort of, don't worry about prostate cancer. It's a disease you die with, you don't die from it. You know, it's just, you know, it's no big deal. And we've become very sort of desensitised to what prostate cancer does to people. Because of course, yes, lots of people do die from prostate cancer, but if you don't, you live with it for a very long time. And you live with the consequences of it for a very long time. And so, you know, that's why we shouldn't be dismissing it with that statement. I hate that statement. So this was a sort of a little test for you as well. Rank these causes of male death in England and Wales 2013 to try and give you a little bit of perspective as well as to why we don't think prostate cancer is maybe as important as you do. So, it's a bit difficult in a large group like this because what you need is the voting pads, isn't it? So everyone can vote.
Lung cancer is the biggest one.
So you say lung cancer is the biggest one.
Suicide.
Suicide.
Heart attack.
Yes. Heart attack. So who votes for lung cancer as number one? And who votes for myocardial infarction, heart attack as number one? Okay. So there's the true figure. So lung cancer, you've got to be slightly careful about these because myocardial infarction is not the only reason men die from heart disease. So heart disease overtakes lung cancer if you add in all causes of cardiovascular death. But lung cancer is right up there. So prostate cancer is below lung cancer. It's below myocardial infarction. It's still pretty high, isn't it? But I find this really interesting because everyone is obsessively worried about testicular cancer. Young men are so worried about testicular cancer. It's right down there. That's not because it is quite rare, but also the survival now is just so incredible. The survival rates, you know, it's very uncommon now to die from testicular cancer. You're more likely as a man to die of breast cancer than you are of testicular cancer.
Breast cancer, I'm quite amazed about everything.
Yeah, it's because it's a nastier cancer than testicular cancer. So it's much rarer. But the outcomes are worse. So leading cause of male death, this just puts the whole of heart disease into perspective. You know, once you add everything in there, you know, it trumps everything. That's why we're obsessed about heart disease. And that's why prostate cancer, when you actually look, it's quite low down. This is from the Office of National Statistics, as England and Wales 2012. So just, again, it just tries to give you a little bit of perspective.
Excuse me, would lung disease be falling now?
Sorry?
2012. Now 2015, is lung disease coming down the list as?
It's coming down. Lung cancer is coming down, but still a long way to go. I'll skip that. But this is again just causes of male death. This is a really sort of good way of looking at it. And it just the size of the box illustrates, you know, how common a cause of male death, and heart disease and stroke are the sort of top 20, you know, the top quarter of that slide. And if you look on here, this is years of life lost, and this is quite important because this is heart disease and stroke, quarter of the board. Prostate cancer is here. And so when you look at prostate cancer in terms of years of life lost, because the majority of men, you know, it's predominantly a cancer that you acquire in your older years. You're older when you're diagnosed with it. If you die from it, your years of life lost are a lot less. Whereas if you get heart disease and have a heart attack at 50, you know, the impact on your life expectancy is so much bigger.
Can I just ask, is there a sign of prostate cancer getting the younger age now than?
I don't know that there is. I mean, I think it's all skewed, isn't it, by testing? That's the problem. The skew is, you know, the prevalence completely depends on who's getting the PSA test. But we touched on this sort of the patient pathway with prostate cancer. There's many steps, aren't there? It starts with, do you have a PSA test? And then it moves on to, does the GP refer you to the hospital with the results of your PSA test? Through to, do you have a biopsy? Do you have treatment? What's your sort of follow-up after your treatment? And then things like having hormone therapy, being followed up long-term with stable PSA, managing the side effects of treatment and survivorship. And what I've done is I've highlighted what are we currently doing in primary care? The reality is mostly what we're doing is we're doing some PSA testing, we're referring people, and we're giving hormone injections. Are we doing anything else? Not really, are we? What could we be doing? Well, certainly we should, obviously we're going to carry on doing the PSA testing. We're not going to be the ones deciding if someone needs a biopsy or not. We refer them, and then the urologist helps you, and you decide whether you're going to have a biopsy. Whether you're going to have treatment, again, is the decision for your specialist and you to make together. Your short to medium term follow-up is with your specialist. But then we should be coming back in. It doesn't mean it's your GP, but it means your community services come back in to administer your hormones, to follow you up if you've got a long-term stable PSA, to help you with the side effects of your treatment, and to help you live with your disease in the long term, survivorship. And that's what the transition we need to see, and that's the challenge we face. How do we achieve that? But we could do it. So you mentioned about survivorship, and this is really just about talking about the fact that prostate cancer is a chronic disease. We talk about diabetes as a chronic disease, and asthma and COPD and heart disease. They're chronic diseases. You live with them for a long time. And prostate cancer is the same for a large number of people. And this is, in America, 2012, this is looking at the total number of people who at any one time are cancer survivors. And you can see that big chunk of pie on the right, again I'm colourblind so I have no idea what colour that is. Blue? 43% of cancer survivors in the US in 2012 are prostate cancer survivors. And urological cancers just dominate, because once you add in bladder, testicular cancer and renal cancer, you're 57% of cancer survivors in America are survivors of urological cancers. So we've got a big role in terms of looking after these people as a chronic disease. And the numbers are going to go up by 2022. And this is in the UK, and this just says, if you take the total male population by 2040, 2.5% of the total male population will be a prostate cancer survivor. And it beats colorectal cancer, lung cancer. Prostate cancer is going to have so many more cancer survivors than those cancers, just simply because for so many people, the outcome is so much better. But that brings its own challenges. So it's this concept of prostate cancer as a chronic disease, and these are the sort of things we've got to think about in primary care. Sexual function, continence, bowel function, those are all kind of quite established, aren't they? That we all get a bit obsessed about continence and erectile dysfunction and sexual function after treatment for prostate cancer. But what we forget sometimes is all the stuff at the bottom, which is really important. The impact of your treatments on your heart. Because we've said this is what men die of, is heart disease. And so if we're giving you hormones that increase your heart risk, what are we doing about that? Especially if people don't know that. If they don't know that hormones increase your heart risk. The same, metabolic syndrome, this is a big problem now. These are the sort of cluster of risk factors that increase your risk of heart disease, like obesity, diabetes, cholesterol. And so metabolic syndrome plays a huge part. Bone health, we know the impact of so many prostate cancer treatments on your bone health, and of course the whole issue around psyche, around our mental health, psychological well-being when we're living long term with treatments and with cancer. And we don't do this well enough. We need to do it better. And I love what the urology specialist nurses deliver in hospital, but I don't know why it's all done in hospital and why we're not doing that more in the community, because I think that's where it needs to be based. I see no reason why most of that care should be taking place in stuffy hospitals. And this comes, just to quote Donald Rumsfeld, because I just love this. This is the whole thing about, the known reports say something has happened, hasn't happened, are always interesting to me, because as we know, there are known knowns. No, you weren't part of this. We were, yeah. And Roger, you were sat in the audience, weren't you, at the first meeting? So these are the statements that NICE came up with. It was a really strange process coming up with these quality statements. Men with prostate cancer have a discussion about treatment options and adverse effects with a named nurse specialist, as should happen. Men with low-risk localised prostate cancer having radical prostatectomy or radical radiotherapy is suitable are also offered the option of active surveillance. That's pretty important, isn't it? I think that's good. Men with intermediate or high-risk localised prostate cancer who choose radical radiotherapy or androgen deprivation therapy receive them only in combination. And that refers back to what Nick was saying about how much better outcomes are in people who get both rather than one on their own. And whilst that's quite specific, it's felt to be so important that it made it in as a quality standard. Men with adverse effects of prostate cancer treatment are referred to specialist services, and men with hormone-relapsed prostate cancer have their treatment options discussed by the urology MDT. People get involved. It's not just one person telling you, oh, I'm not sure we can do very much here, or this is my current favourite. You get discussed by the wider group. Now, Tackle responded, or it wasn't a response, was it? It was a, what's the word for a response that happens before something? It's just, you submitted this tonight, didn't you?
Yes, we made a proposal based upon 9 quality standards in the treatment pathway that we thought would be the sort of gold standard of prostate cancer treatment. And John just showed you 5 statements, but there are only 3 of those were in the 9 that we go up. So there are 6 missing.
Yeah.
Things like, oh, well, you've got them here. Yeah, you know, everybody having equal access to treatment irrespective of where they live, and having an informed decision process where members of the family and everybody's included in a holistic, you know. Another thing is, if Keith Cass were here, he would say it's very important that people have control of their own care plan, because people like Keith go on the internet every single day, and he thrives and survives by being in touch with the latest research. That's not for everyone, but there are people that want to take care of their long-term plan. That was not included. Palliative care or end-of-life care available to you before the end of life was important. Those were things that have yet, not made it into the standard. And in fact, the article that John mentioned in Urology Men's Health, we're actually going to talk about all 9, and hopefully we will get a more rounded view. Sorry, John.
No, that's great. And the frustration, I think, is that we were so restricted by NICE methodology. So you might think that all those things are really obvious things that should be part of a quality service for men with prostate cancer. And then NICE will say, well, no, we can't put that in. So you can't put in anything about risk assessment and referral, because this is a prostate cancer quality standard, so it's about men with prostate cancer. So we've already, we can't do that because that's pre-diagnosis, so you can't talk about that. So PSA testing, can't talk about it. And again, you can't put anything in that goes against anything that's recommended in the actual prostate cancer guidelines. So even though evidence may have moved on since the guideline, or you may want to have a different emphasis, you have to be consistent with previous guidance. And so it's very restrictive, and I think that's why I would question. I think it's a useful document, but I don't think it's groundbreaking, game-changing. I'm not sure what impact it's going to have on the ground. Are you?
No.
So in some, I did have your 9, but for the sake of time, so I'm going to skip over them.
Yeah, sure.
So is the NICE quality standard useful? Yeah, I suppose it's useful. It sets some standards. Did they get the quality statements right? I would conclude that the statements are right, they're just incomplete. And they left off a lot of the things that you left off.
Yeah.
And we'll save other thoughts for the end. Now I'm going to really skip through this because I've got this ready, but Prostate Cancer UK are not quite ready to share this, so you just have to close your eyes when I skip through it. So this is just something that Prostate Cancer UK are working on in the sort of gulf that's left at the moment, in terms of we're waiting for Protect study to report. We're waiting for a big research project that I'm going to mention in a minute. Prostate Cancer UK are funding. We're waiting for some changes, and what do we do at the moment is holding measures in terms of trying to have some sort of consensus on best practice for PSA testing. And God, it's just so controversial. And I think the key thing is, there is never, you get people together, we get you guys together, we get Prostate Cancer UK, GPs, urologists, oncologists, we're never going to agree, because there isn't a right answer. We have to hope that we're all aiming for the same things, from subtly different angles, but there is a difficulty in reaching consensus, because it is so confusing, complicated. So I'm going to tell you a little bit about what we've done. So this is some, to reflect the lack of clear guidance for primary healthcare professionals on what should we do about testing younger men who want a PSA test under the age of 50, because prostate cancer risk management program doesn't really discuss it. What should we do about this concept of baseline testing, having a PSA at a young age to determine your future risk? What should we do about trying to target men at higher risk? We talked about Afro-Caribbean men earlier, men with strong prostate cancer family histories, for instance. What should we do? We're not doing anything at the moment. How can we do this better? And so this was a group that PCUK have set up with, chaired by Peter Kirkbride as an oncologist, and very, very broad membership. So TACL represented, I was there, Chris was there, large group of people, and also went out to what's called a Delphi survey, which is going to the wisdom of the crowd, as an Oracle at Delphi approach, of 335 healthcare professionals, and also 3 focus groups on men with prostate cancer. And so they've come up with a list of statements, which you can't see yet, but they're in draft form, and I know there's some issues. Chris, you're unhappy about statement number 1. I'll quickly flick on to statement number 1. It says the PSA test, even when combined with the DRE, should not be used in a UK population-wide screening programme for asymptomatic men over 50. So that's quite a strong statement. You may wish to think about that, but those are the 5, 6, 7, 8, 9, 10, 11, 12, 13. You ain't seen those. You ain't seen them. They will come out, and I'm not pretending that that you're going to think they're all brilliant and all correct, but they're an attempt. It's a well-meaning effort to try and help us in primary care. Again, for the sake of time, I'm going to move on. But why do we need help in primary care? Because there's so much inconsistency. It's just a nightmare. So these are just some quotes. So this is a British Journal of Urology editorial that's just been published online. It's not yet been published. And Stacey Loeb, who's a urologist in the States, starts her editorial with, "The days of using 1 PSA threshold to trigger a biopsy for all men are over." Okay, I would agree with that as a statement. Then I go to a talk given by one of my local urologists, who will remain nameless, and he said to my assembled group of GPs, having a PSA test is consenting to have a biopsy if the result is abnormal. And I sat there and went, whoa, really? Do we not want to have a conversation about risk? Do we not want to have a bit of a think before we put someone through a biopsy? You've all had biopsies. You wouldn't necessarily want to have one if you didn't really need one. I suspect. It's a process. It's an unpleasant procedure. It's a procedure with risk, and also being diagnosed with prostate cancer has its implications. And you may decide, you may want to make an individual decision about that. So I really didn't like that statement. Then I get patients coming to see me saying things like, yeah, my PSA was 9. This was I can't remember how old this guy was. In his 60s. My PSA was 9 2 years ago. Last year it was 12, and now it's 18. So my GP thought it might be a good idea for me to come and see you. And I just, where do I begin? So that just depresses me. And then you get GPs saying things to me like, oh no, I just do a PSA on everyone. It's just easier that way. I just tick the box. And you discuss it with people? No, just do it, and then it's done. Okay. And then you get the opposite extreme of people saying, oh, I don't need PSAs, they're useless. It's a rubbish test. A complete waste of time. So how the hell do we expect GPs to have who aren't specialists and interested in this condition to know what to do? We're so inconsistent. And the US task force recommendation a few years ago in the States that advised GPs in the States not to PSA test has had a big impact in America. And this has just been released at the AUA in May. And they saw that the population that's been most affected by the task force recommendation in the States was the very people who stood to benefit the most from having a PSA test. So the men aged 50 to 70, the PSA testing rate has dropped by half. But for men over 70, it's unchanged. And for men aged 40 to 49, it's unchanged. So I don't think that's a great success for the task force statement. So that makes it very difficult. And as I say, this puts the GP in this kind of dilemma of what do I think? What am I supposed to say to people? It's really hard. NICE are updating their referral guidelines. This is about to be published, and this is the suspected cancer referral guidelines, and they're saying refer men using a 2-week wait pathway if their prostate feels malignant. Consider a PSA test to assess for prostate cancer in men with urinary symptoms, nocturia, urgency, frequency, erectile dysfunction, or visible hematuria. I'm really pleased to see that come in. Men who have blood in their wee, traditionally we've just looked at bladder cancer, and now we're going to start to look for prostate cancer as well. And refer if their PSA levels are above the age-specific range. Okay, 2-week wait if you're above the age-specific range. So that's good. But what do we do in other conditions? If I test your cholesterol I don't treat you based on your cholesterol number. I treat you based on your risk of heart disease, because that's what I'm trying to prevent. And we accept that your cholesterol is just one component of your risk. And what we do is we feed your cholesterol result into that, which is a piece of software called Q-Risk. And that tells me your risk over the next 10 years of having significant cardiovascular disease. And I fed in, this was a 63-year-old male, white, from my practice postcode, BS48, light smoker, not diabetic. What else did he have? He had a cholesterol ratio of 5.1, blood pressure, systolic blood pressure 165, and a bit overweight, and his risk came out at 40% over 10 years.